So I'm a big believer in targeted physical therapy, and we have excellent physical therapists right here in town who can help with that. Now, as I mentioned, I do have an ultrasound machine in the office that has really opened up a world of treatment options for us. Specifically, I want to go through a couple different types of pathology or joint issues that have been very much helped by having the ultrasound guidance. One of them is called frozen shoulder. Okay, has anyone heard of frozen shoulder? Okay, all right. I see some familiar faces, and all right. Frozen shoulder is something, or also it's known as adhesive capsulitis. Now, if you think about the name, adhesive capsulitis means that you have a capsule around the joint, and itis, anytime you see that, think about inflammation. So arthritis is inflammation of the joints, with arth referring to the joint. Adhesive capsulitis means you have some reason for inflammation about the joint capsule. Okay, that's the capsulitis part of it. The adhesive means that you actually are developing small kind of sticky adhesions on the inside of the capsule. And so a lot of times folks will come into the office and they'll not even be able to raise the shoulder up past here. Or if you have them take it out to the side, they'll only take it up to about 90 degrees. And then if you hold them here, normally you should have a full arc, full range of motion at the shoulder joint. And a lot of times folks are only able to move about 20 or 30 degrees. And depending on where they're at in their disease process, it may be very painful and stiff, or it may just be stiff. So the reason I say that is the good news about this is it's normally self-limiting. Means normally if you give it enough time and if you work at it, if you keep the shoulder moving, it will get better. But there are ways that we can sort of help speed this along, and specifically that's by putting a little bit of lidocaine and steroid in the shoulder capsule itself. And we can do that with the ultrasound. You don't have to use an ultrasound, but I've found that more likely I'm able to consistently get the steroid into the ball and socket joint of the shoulder and get the steroid right where we want it to help break up those adhesions. And then the lidocaine, of course, helps that to be a relatively comfortable procedure. Normally, right after the injection, people can move the shoulder a little bit more and say, oh, I see a decrease in pain already. Now, the steroid itself is not the mainstay of treatment, but rather that helps with the pain while the person goes through physical therapy. The mainstay of treatment is to keep the shoulder moving because the joints are made to move, and the more you move the better. And especially that's the case in a diagnosis of frozen shoulder or adhesive capsulitis. So we use the steroid with a targeted injection in conjunction with physical therapy for gentle range of motion. Those folks normally require 2, sometimes 3 injections, but each time they're about 30% better when I see them back in the office 3 or 4 weeks later. So we've really seen some good results with that. Another one is hip injections. So the way we used to have to put corticosteroid in a hip joint is using a fluoroscope, which, as you know, has radiation involved. I'm very pleased now that we have the ultrasounds that we can inject the hips in the office and we don't have to send the person to the hospital and subject them to radiation. The ultrasound, of course, is the same technology as we use for pregnant women, and so there's no radiation involved. So we can inject a hip right in the office. Now, we do this in a couple different cases. One is if we already know the person has significant arthritis and they hurt. Another, however, is if we're trying to make a diagnosis and we can't tell if this is coming from the ball and socket joint of the hip or if it might be coming from the musculature or tendons around the hip. So that really helps us at the kind of the fork in the road to say, is this from the joint or is this outside the joint? By putting a little medicine in there and seeing how they feel after the injection, that can help us with that decision tree. Another is what they call de Quervain veins, and that is when you have a lot of pain on the radial side of the wrist, especially with motion of the thumb. And this can happen for different reasons. Sometimes it can be trauma. Sometimes it can be if you haven't moved the thumb for some reason because it's immobilized, and that can be very, very painful. Using the ultrasound, we can watch our needle go in, and we can basically put the medicine around the tendon but still inside the sheath where the tendon slides back and forth. and then we can see the person move the thumb with less discomfort. We've seen good success with that as well. Has anyone ever had plantar fasciitis? Anybody? Okay, we got a few folks with that. Has anyone ever had an injection for plantar fasciitis? Has it ever been so bad that you needed an injection? Okay. Was it painful? Yes. Yes, ma'am. It's probably one of the most painful injections that you can have is in the plantar fascia. My experience, however, though, has been with the ultrasound. We are able to watch the needle as it goes in, and we're able to adjust the trajectory of the needle because we watch it on the ultrasound screen, and then we can avoid hitting the bone. A lot of times, the reason that injection is so painful is because as the needle goes in, you gently end up inadvertently hitting the bone and then having to pull back, readjust the needle, and then sneak underneath the bone. With the ultrasound, however, you're able to make that change before you hit the bone, and the patient is able to have the injection with less pain. And this has been my experience in Greenwood. When I ask a patient who's had one without the ultrasound and who's had one with the ultrasound, that patient says that there's less pain when you use the ultrasound. So that's a good reason to do this, to have it a more comfortable procedure. Now, I want to speak about one other type of treatment, and that's called a needle tenotomy. And the purpose of this is for folks who have, instead of tendinitis, what is actually called tendinosis. Now, the difference, I think most people have heard of tendinitis, where you have an inflammation around a tendon. Tendinosis implies that this has been more chronic. So normally we think about more than 6 or 8 weeks or so, kind of tips you more into the tendinosis phase, and you don't really have so much inflammation as you do chronic tendon injury. What's really interesting is sometimes you actually don't see tendinosis on an MRI because the MRI is relying on water or swelling for a signal. And a lot of times, like I was mentioning in tendinosis, if it's been going on for a couple of months, the water may not be there anymore. The swelling may not be there, but you still have the injury. Whereas on ultrasound, you can see this because it shows as abnormal tendon structure. So on the ultrasound, what we'll do is we'll look at someone who has perhaps chronic elbow pain, like tennis elbow. Anyone had tennis elbow before? And those people don't necessarily have to be tennis players to get tennis elbow, right? Okay. So you can get that chronic elbow pain that really hurts when you try to reach out, grab a gallon of milk out of the refrigerator, pull it out, and you just get that awful pain right through here. So that's one example of sometimes folks come to the office and they have this for 6 months or so, or even longer. And they're in what we call the tendinosis phase or the chronic tendon injury phase. When we put the ultrasound on, we can actually see abnormal tendon structure. And then we can use a needle, and on the screen we can actually see the needle go back and forth through that area of abnormal tendon structure and basically make a targeted destruction of that particular part of the tendon that's hurting so badly. Now, after the procedure, there's a couple different things that we do. One of them is we actually try to promote blood flow to that area because we've made targeted injury. We actually want an inflammatory response now. And so we actually give the person a little nitroglycerin patch. And it's a very small patch that goes right over the area that hurts the most. And the purpose of that is actually to increase the blood flow to the area that's been chronically injured and now acutely injured from the procedure. So that brings more blood flow, more healing to that area that's been hurting so badly. We also ask the patient not to take what we call non-steroidal anti-inflammatories, such as ibuprofen. Okay, you actually stay away from that because we desire to have the inflammatory response to bring healing to that tendon. And then lastly, again, we work with, in conjunction with physical therapy, to begin strengthening that tendon unit. So for instance, if it's tennis elbow, then we work on the extension of the wrist to where these muscles originate on the outside of the elbow. So does anyone have any questions about that process? Yes, ma'am. Yes, ma'am.
And it's located in one spot, and it just, I can't stand for long anymore.
Yes, ma'am.
Hard to walk.
Yes, ma'am.
And
Well,
it's in my left side, like over here, where it's finding it. It's like something place.
yes, ma'am. Well, I'm glad you brought up back pain, because back pain can be something that bothers a lot of folks, and it can be very difficult to treat. So I'm glad you brought that up. Now, back pain, you have to do a thorough evaluation, especially when you first see a person, because there are many causes for back pain. There could be osteoarthritic changes in the spine itself. There can also be a specific type of arthritis where the spine comes down and meets the pelvis at what they call the SI joint. And that's normally at the low back, right around the belt line, but just off to the side, one side or the other. And normally you can stick a finger right there where it hurts. Sometimes the sciatic nerve can also be irritated and can send some signals down the back of the thigh and the hamstrings. That can also be very painful. So it is important to have an evaluation of your back. Sometimes it can be just musculotendinous, which some physical therapy and rest and some targeted strengthening can really help. But sometimes it also can be helped by an injection in the lower part of the back, where, again, not anywhere close to the spinal cord, but off to the side, where the spine comes down and meets the pelvis. So I appreciate you for bringing that up.
Well, I've had injections, and it didn't last but 2 hours. What is that?
Yes, ma'am. Well, it would be tough to say. I'm not sure if they actually did. There's a couple different kinds of injections. One is when they do what they call an epidural steroid injection, or ESI, and that actually is adjacent to the spinal cord. Yes, ma'am. Now, I personally don't do those. My training was normally that's someone who's had some advanced training in like pain management or anesthesia normally does those type of injections. But I do the ones that off to the side at what they call the sacroiliac joints, and we can do those in the office with the ultrasound. So, yes, ma'am. Now, one other thing with the tenotomy procedures that I was talking about with the chronic tennis elbow. Now, you can get these sorts of injuries in other places. For instance, the rotator cuff. All right, the rotator cuff is actually, they call it a cuff, but it's a series of 4 different tendons that go around and help to stabilize the head of this long bone here in the humerus in the shoulder. So as you go through this range of motion, it helps to stabilize that. So, excuse me, it is possible and relatively common to get some type of tendinosis or overuse injury of one of your rotator cuff tendons. And so that same type of tenotomy procedure where the needle passes back and forth through the area of injured tendon, you can also do for a rotator cuff. And as well, sometimes people get knee pain in the patellar tendon just below the kneecap, which can be very painful, especially in runners and jumpers, excuse me. And sometimes those patients benefit from a tenotomy procedure as well. So, well, I appreciate your attention this morning, or this afternoon, excuse me, and I wanted to just briefly go through what primary care sports medicine is. I hope you have a little bit better taste of what we do and what we offer. We have excellent orthopedic surgeons at the office who I work in close conjunction with, and so if it's a case that ultimately needs surgical referral, we work hand in hand together in the office. So, and I just wanted to give you kind of a sampling of a couple of different things that I do. This was not an exhaustive list of the things that we can do, but I hope it gives you some idea now of more of what a primary care sports medicine physician does in the office. So I'd like to open it up for questions. Yes, ma'am, that's a good point. The corticosteroid injections, we see a very wide spectrum of response to those. Sometimes a person says they didn't help at all. Sometimes a person says, oh, they helped for a couple of weeks. Sometimes a couple of months. And so there's many factors that go into it. One is how bad the arthritis is. 2 is how much you're using the joint. Some folks just want to be able to walk around the grocery store without pain. Some folks actually want to try to jog or do something like that. So it really depends on how much you're using the joint.